chronic opiates. On one hand, we all are really well aware of the terrible public health emergency that there is the growing rate of prescription drug abuse and increasing overdose deaths. But then on the other hand, we also know that there are some patients who are really benefiting from chronic opioids. And so today's talk is really about how to strike the right balance to making the management of chronic opiates safer and more effective. So I want to begin by telling you the story of chronic opiates, and it's a story that begins long, long ago in the 1980s, a simpler time when everyone thought that the addiction risk from opiates was very, very high. Cancer pain was terribly, terribly undertreated, and the idea that you would treat non-cancer chronic pain with opiates really didn't exist. So fast forward to the 1990s when a really interesting sociological development happened. So driven partly by a cancer patient advocacy movement, in addition to very aggressive marketing of OxyContin, the new sort of paradigm came up, which is that the addiction risk from opiates was actually very, very low. And the big tagline was that tolerance does not equal addiction. And the treatment of cancer pain with opiates dramatically improved in a very, very good way. But then what happened in the 2000s is another interesting sociological development where all of a sudden opiates started being used very, very widely for non-cancer chronic pain, and addiction rates went way high. And so that's kind of where we're at now. It's how we ended up in this pickle, where on one hand, we are suddenly very aware that chronic opiates have very significant addiction risk. But then on the other hand, we know that there are some people who are really benefiting from chronic opiates. And so we're at sort of this really sort of crucial crossroads right now of how do we slow this pendulum down and somehow get it to stay somewhat in this happy medium rather than swinging wildly in each direction. And so I'm going to start out by talking about sort of drilling down and talking about what are these risks of chronic opioids. And so this is sort of a list from the CDC from November of last year, pointing out that prescriptions for opioids have tripled in the past year, that 1 in 20 adults in the U.S. has now at one time taken a prescription opioid to get high. And this is a pretty big deal. I mean, so when I was in high school in the early 1980s, the idea that somebody would take a prescription opiate pill recreationally really didn't exist. And now, though, among 11th and 12th graders, prescription opioids is really one of the most sort of abused recreational drugs around. And sort of right along with this big skyrocket has been a skyrocketing deaths due to prescription opiates, which are now more than the risk of overdose of cocaine and heroin combined. And so this is just a graphical representation of what I just said, just showing this tripling in the past year, the dotted line being of opiate sales and the solid line being of opiate overdose deaths. And this is the absolutely most recent data. So this is a report that was issued by the Institute of Medicine earlier this week. This is a study that they did of the military showing the percentage of active duty soldiers. So these are active duty soldiers. These are not veterans. These are active duty soldiers who reported abusing prescription drugs in the past 6 years has gone up sort of 6 times, from like 2% to 12%. But clearly some patients do benefit from chronic opiates. And so what can we do to make prescribing opiates safer and more effective? So first, let's look at some data about, do chronic opiates for non-cancer pain even work? And so there's actually a fair amount of data from short-term trials. So the one really recent meta-analysis from 2006 found 46 randomized controlled trials over 6,000 patients and found that the standard mean difference was a decrease in pain of 0.6, which was very statistically significant. But then the real sort of question is, what about long-term efficacy? So we can show that people benefit in the short term, but what about in the long term, that's how we're talking about using these drugs. And there is not a single randomized controlled trial lasting more than 6 months. So a Cochrane review from January 2010 could not find a single randomized controlled trial. They did sort of end up concluding that there was weak evidence from 26 non-controlled trials suggesting that some degree of efficacy may be sustained. So I think it's really important to ground ourselves here first in that there's probably some efficacy for chronic opiates in non-cancer pain for some patients, but that the magnitude is not huge. And so what about opiates at high doses? Because I think this is really the real crux of the problem. And that so of all of these 46 randomized controlled trials of short-term efficacy, none of them were using high doses of opiates. So all of those trials generally used opiate doses that were really quite low, less than 60 morphine equivalents per day. And then the question of safety of high-dose opiates is even more sort of chilling and worrisome. There's an extremely high correlation between a risk of overdose death and high daily dosing, with an exponential rise seen above 100 milligrams of morphine equivalent per day. And so here's that data. So this was actually a study that was done here in Seattle at Group Health, published in the Annals 2 years ago, where they sort of looked at data from thousands and thousands of patients in the group health system who were receiving chronic opiates. And then they tracked them by what their opiate dose per day was. And at high dose, or at low doses, the risk of serious overdose was rather low. But then there was this exponential increase in overdose risk that happened once you got to 100 morphine equivalents per day. So this is chilling. It's bad. And so we clearly need to have really, really clear upper limits on the dosing of chronic opiates. And it really sort of comes down to the dramatic difference between treating chronic pain with opiates and treating cancer pain. So still the way that the vast majority of teaching happens, training people how to use opiates, is in the paradigm of cancer pain, in which it's absolutely appropriate and shown to be effective to escalate the dose of the opiate in cancer pain until you've achieved pain control. And so it's not too hard to understand how that would have just bled into sort of the management of non-cancer chronic pain. But they're actually completely different clinical entities, and the idea that you would use the same treatment approach with opiates for cancer pain as you would for chronic pain is, I think, really the crux of what has gotten us into trouble. Because for non-cancer chronic pain, low doses generally work fine for years and years. So the idea that people become tolerant of the analgesic effect of opiates for non-cancer chronic pain is really not really borne out in clinical practice. And I think so that sort of questionable efficacy of high-dose opiates for non-cancer pain in combination with the extreme risk that we just saw of high-dose opiates is very dangerous. And I think it's also useful to look at not just the risk of overdose death that can happen from high-dose opiates, but what about all the other sort of terrible things that high-dose chronic opiates can do? And so here's a quick list suggesting that sleep apnea can be made much worse. And in fact, when they did epidemiologic analysis of the risk factors for overdose death with chronic opiates, sleep apnea really rises high as a very, very high risk factor for overdose death in people on chronic opiates. Hypogonadism, I think Brad Anawalt is sort of my special source for saying that the number one cause of hypogonadism at the VA is chronic opiates. The really sort of troublesome concern about hyperalgesia. So can you permanently alter someone's pain perception and make them sort of extra sensitive and troubled by pain by treating them with chronic opiates, and just the general deconditioning and weakness that can come from making somebody less functional with high-dose opiates. All of these things together with this overdose death makes the whole idea of treating people with chronic high-dose opiates dangerous, should take pause. And so we should really be really cautious when patients are requesting higher and higher doses. In non-cancer pain, a failure to respond to low doses really should be a red flag. And doses that are above 60 or 80 morphine equivalents per day have untested efficacy and really major risk of harm. But this is a really difficult situation. So here you are, you're sitting in the exam room with somebody who is on a low dose of opiates, and they're saying, doc, I just really feel like I need more. What should you say? How do you prevent the sort of gradual dose escalation as you would in cancer pain? And so you just got to sort of look people in the eye and say, honestly, I just do not believe that higher doses would be safe for you, and this is the maximum dose that I feel comfortable prescribing. And just having that as a sort of deep in your heart, this is sort of the maximum dose that feels safe and effective is really important, and really important to be able to communicate directly. So in addition to having a really clear upper limit of the dosing of opiates, another really important part of making chronic opiate prescribing safe is the use of care agreements. And the most common pitfall that happens when people are using care agreements for chronic pain therapy is to think of them as contracts. I mean, it's really hard to get away from the idea of calling these documents pain contracts. But I think that that terminology really gets to sort of the very heart of how they are misused, and how in many cases we miss the great value of using a care agreement, which is that this is really best thought of as a communication tool. The problem with a contract is something that is long and full of fine detail that people just don't read. I mean, people sign a contract and then file it away. Maybe they'll have their lawyer read it, but contracts is not something that people read and really internalize. But that's really what a care agreement needs to be. A care agreement needs to be the clear communication of simple written expectations of what the rules need to be for the safe prescribing for that patient to be using chronic opioids. And if you are really able to clearly communicate those simple rules and expectations and really feel confident that the patient has understood them, and then the patient's not able to follow them, then all of a sudden that is a real useful red flag for you that opiates might not be safe for that patient. If somebody was not necessarily aware of what the rules of prescribing were, and then they mess up and don't follow one of those rules, you could say, well, maybe they just didn't quite get it, or they didn't understand, and it's much less of a clear, actionable red flag for misuse if they didn't clearly understand it. And so what about a history of substance abuse? I called chronic opiates in medicine one of the hardest nuggets that we face, and I think the hardest nugget within that hard nugget is the comorbidity of patients who have chronic somatic pain and a history of substance abuse. And I would say that there's really good epidemiologic data that even patients with a distant history of substance abuse are at much higher risk of abusing opiate medications. And I think the big sleeper on the problem list that is often overlooked is chronic hepatitis C infection. And while it's true that there are some people who have chronic hepatitis C who got it from a blood transfusion in a car accident that they had in the early 1980s, the vast majority of patients with chronic hepatitis C infection got it related to illicit drug use. And so anytime you see hepatitis C on a problem list, or get somebody to admit to having a history of substance abuse, right there you have immediately increased dramatically the risk that that patient is going to misuse chronic opiates. And so then what about somebody with ongoing substance abuse? So here's sort of the hardest nugget within the hard nugget within the hard nugget. I mean, this is absolutely wrenching, especially if it is a patient who you have sort of developed a good therapeutic relationship with, somebody who, maybe on some levels you really trust, you really want to help this person, and that's why we all went into medicine, is to help people. And you know that they have clear pain, but you also know that they are sort of continuing to struggle with ongoing substance abuse. And it can be really, really hard to say, oh, I'm going to prescribe them some opiates as a risk reduction. I would rather them come to me for their opiates than have to buy them off the street. And you can sort of somehow convince yourself that you're somehow doing a good thing for them. And I would say that the rock solid advice from substance abuse experts is that is absolutely not the best thing for that patient, that patient needs substance abuse treatment, that they need methadone maintenance perhaps, but the idea that you're going to treat their chronic pain with ongoing chronic opioids is just so fraught with the potential for doing harm and dose escalation that except for very narrow clinical situations where the clinician is very well trained in addiction, that absolutely should not be happening. All right, so the next really important tool for making chronic opioids safer is the careful and judicious use of urine toxicology screening. And this is really perhaps the most valuable tool in the toolkit for managing chronic opiates. This whole issue can be so frustrating and foggy in that there are very few other situations in medicine where a patient is there in the exam room and is not telling you the truth, is trying to scam you. But there's definitely a subset of people who are on chronic opiates who don't really have pain in their back, but really they have pain in their soul. But they're telling you that they have pain in their back, and they're sort of there, sort of, lying to you. They're manipulating you, and you have this nagging sense that they are manipulating you. You have this nagging sense that they are probably not telling you the truth, but you can't tell for sure. And it's this sort of foggy sort of risk assessment that is really, really difficult. And so that's where urine toxicology screening can be so useful. I mean, it's one of the very few situations where you can have some hard actual data or evidence that can cut through that fog and identify a patient who is at extremely high risk for abusing prescription drugs and shouldn't receive them. And so there's no question that every patient on chronic opiates needs to have serial toxicology screening. And I can tell you, when I do a lot of chart reviews of difficult patients, it's pretty remarkable how often patients will get prescription opioids prescribed for very long periods without having urine toxicology screening, which is absolutely not the standard of care. So one of the other big pitfalls that happens when people order a urine toxicology screen is failing to require the patient to leave a urine sample on the day that it's ordered. So again, when I'm reviewing these difficult cases, it's pretty remarkable how often a urine toxicology screen is ordered on a given day, but then the sample somehow kind of never makes it to the lab. And so this is another really, really key important phrase to always have in mind so not only must patients get urine toxicology screening on a regular basis, but they also need to be told that leaving today without giving a sample is not okay. If you leave today without giving a sample, I'll have to consider that a positive test and we'll have to stop your opioids. Because if you allow a patient who knows that they're going to fail a test to leave without giving a sample, then the test loses much of its ability to detect abuse. So like right then and there, all of a sudden this super valuable tool that you've got suddenly loses its value. And so there are all kinds of logistic workflows that clinics develop to get around this. You know, on one hand, you can sort of require a patient to sort of provide the urine sample sort of up front at the beginning of the visit, and then they won't get their renewed prescription without leaving a sample. And that works for some clinics. For other clinics, it gets logistically sort of tricky to sort of always flag those patients and get their urine samples at the beginning of the visit, and that doesn't always work. And so at the very least, though, you've got to communicate to the patient that we're going to do a urine toxicology screen today, and I need you to know that you can't leave today without leaving the sample, or I'm not going to be able to continue prescribing opiates for you. And so urine toxicology screening is this super valuable tool, but it's also super complicated, and there are all kinds of intricacies and pearls and pitfalls in their interpretation. The easiest sort of finding on urine toxicology screen, perhaps, is cocaine. So extremely high specificity, virtually no false positives, and excellent sensitivity in that epidemiologic studies show a very, very high correlation, very high relative risk between cocaine on a urine toxicology screen and prescription drug misuse. So this is really a cocaine positive is one of the clearest indicators that a patient is not a safe candidate for chronic opiates. Oxycodone is really, really tricky because it's a semi-synthetic opioid, and so it is usually not detected on the opiate assay on the toxicology screen. And so I sort of want to apologize that I skip back and forth between the term opiate and opioid. The main difference in definition is that an opiate is technically really something that is derived from morphine, a naturally occurring sort of opium derivative, whereas a synthetic opioid, opiate-like, is not derived directly from morphine or opium, and so many drugs, prescription drugs of abuse like oxycodone, are semi-synthetic. The opiate assay that's on most urine toxicology screens is really pegged to detect morphine. So it's pegged to detect opiates. And so opioids, the purely synthetic or the semi-synthetic, are going to have a weak specificity for that assay. And so you will often get a negative opiate assay in somebody who has oxycodone in their system. And you will especially get that for methadone. So methadone is kind of the classic purely synthetic opioid. And so that's why a urine toxicology screen has to have a separate assay for oxycodone, separate assay for methadone, in order to pick up those semi-synthetic and synthetic opioids that will not necessarily turn an opiate assay positive. You know, but oxycodone is kind of tricky because it's a semi-synthetic opioid. And if you are on a very high dose of oxycodone, you can actually sort of overcome that slight misfit with the opiate assay. And so somebody on a very high dose of oxycodone will actually have a positive opiate assay, although somebody on a low dose of oxycodone will generally have a negative opiate assay. All right, and so that's the tricks and problems with false negatives. And what about false positives? And so the main problem, the main culprit for false positives is amphetamines. So the screening assay for amphetamines has this tremendous amount of cross-reactivity. So many drugs that we use that we don't even really think of as stimulants will have enough affinity with the opiate ELISA assay that you can actually get a positive amphetamine result on the urine toxicology screen. I mean, the list is like 20 or 30 or 40 drugs long. The ones that we use the most to be aware of are bupropion, phenergan, and then of course the amphetamine ADHD drugs that we use, like Adderall and Vyvanse, will always give you a positive amphetamine ELISA assay. You know, but then interestingly and sort of confusingly enough, So the other most commonly drug-used stimulant for ADHD, the methylphenidates, like Ritalin and Concerta, do not cross-react. Their amphetamine screen will be negative. So this is tricky stuff, and so this is a really valuable tool, but you gotta at least get under the hood somewhat to know how to use them. So because of positive ELISA, amphetamine will always will so often be a false positive. It's really important that your lab will automatically do a GCMS confirmation to assess whether the positive amphetamine screen was due to crystal meth or bupropion or Adderall. And so most assays or most panels will sort of automatically trigger that, but just sort of be aware of just how sort of weird and odd this can sometimes look. And make sure that the assay that you're ordering will trigger that confirmation. All right, so what about diversion? So we've talked about an unexpected positive result on a urine toxicology screen being almost always a sign of drug misuse, a big major red flag. But what about when you get a negative, an unexpected negative on a urine toxicology assay? And I mean, this is definitely something to be aware of and watch out for, because diversion is a huge problem. When we talk about what a giant problem prescription drug abuse is, some of those patients are sort of scamming doctors and going and getting their own prescriptions, but many of them are buying it off the street. And where are those pills coming from? An awful lot of them are coming from people going to doctors, saying that they have pain, getting prescriptions, not actually taking them themselves, but then turning around and selling them to others. And so diversion is a huge problem, something that we need to try to detect, but it's tricky to detect because most of these urine toxicology assays were really designed not to be used in a chronic pain setting like this, but a lot of these assays were actually designed to be used in emergency rooms. Sort of when somebody is wheeled into an emergency room unconscious, you do a urine toxicology screen sort of rapidly in the emergency room to try to identify, are they overdosing? Are they overdosing on something? And so they're generally designed to not pick up very small levels in the urine. And so that can be a really tricky thing. If somebody is on a low dose of a chronic opiate, exactly when they took their last dose will determine whether or not their opiate assay or the methadone assay or whatever they're taking is positive or negative for that drug. So if you get an unexpected negative, it's possible that that patient may be selling pills to others, but does it really mean that they're not taking the medicine? Well, it depends a lot on how high the dose is that they're supposed to be on. So if somebody is supposed to be on a super high dose of an opiate, and they come in and they have a negative toxicology screen, and they're not sort of an obvious withdrawal in your exam room, that's a very high risk for diversion, and that should be a major red flag. But if somebody is supposed to be on a low dose of an opiate, and maybe they ran out a day or two early, and they haven't taken it in a day or two, it would be completely expected that they would have a negative finding on their toxicology screen. And so that should be sort of maybe a minor red flag, something to sort of keep in mind and sort of put into their context, but can be tricky to detect diversion in that case. All right, so now I want to sort of spend a little bit of time talking about methadone, mainly because this is an odd drug. Methadone is an odd drug that has now become extremely commonly used for chronic pain. It's very widely used now. It's implicated in a great number of the overdoses that are skyrocketing, and it's got really weird extra quirks to it that present extra challenges for prescribing. So what is so unusual about methadone? So methadone has this extremely variable idiosyncratic dose response. It's got a variable speed of metabolism, and it's got this sort of chillingly weird, extremely long half-life that can be as much as 128 hours. So that over the first 2 weeks of starting methadone, the serum levels of methadone and its metabolites slowly accumulate So the respiratory depression of that dose will slowly rise. So the respiratory depression that you'll get on a fixed dose of methadone for the first few days of prescribing is going to be much less than the respiratory depression that you get later in that week, continuing to take that same dose. Because of this crazy long half-life, it can take more than 7 days to reach steady state on a fixed steady dose. And so that's really where this risk of unintentional overdose comes. So in what is so tragic about so many of these cases. So, I mean, a lot of times when we think of overdoses, we think of sort of drug addicts who are injecting large amounts of heroin, and they got sort of a extra potent batch, and they didn't really, you know, or they were sort of really also very depressed, and you know, maybe they had some suicidal ideation as well. But so many of these chronic pain overdoses are people who are not feeling suicidal at all, and who are just taking the drug that was prescribed by their doctor and are unintentionally overdosing and sometimes dying sort of based on the prescription that they got from their doctor earlier that week. And so it's really important to also keep in mind sort of what these sort of comorbidities are that put people at very high risk for these unintentional overdoses. And so it is combining opiates with benzodiazepines, combining opiates with even sort of mild or moderate amounts of alcohol use, and like I mentioned before, sleep apnea. This is sort of the typical perfect storm of the person who dies of unintentional overdose due to methadone. The other really tricky and important things to know about methadone is that it only comes in these extremely potent tablet sizes. So the 2 tablet sizes that methadone comes in are 5 and 10 milligrams. And that's actually the same tablet size that oxycodone comes in. And so you might think that there's something rational about that says that, you know, gee, maybe 5 milligrams is sort of the lowest sort of good dose of methadone, just like it's the lowest good dose of oxycodone. And, you know, maybe that 5 milligrams of methadone is kind of roughly the same as that 5 milligrams of oxycodone. But it actually turns out that methadone is extremely potent. It's so much more potent than is reflected in these tablet sizes. So the smallest 5 milligram tablet size of methadone is actually 3 to 4 times as potent as that smallest 5 milligram tablet of oxycodone. And we also get lulled into sort of not realizing how potent methadone is, because for many of us, our first experience of sort of prescribing or being aware of methadone is taking care of heroin addicts in the hospital who are on very, very high doses of methadone as methadone maintenance to treat their heroin addiction. And so they can be on these very, very high doses of methadone, like 60 milligrams a day or 100 milligrams a day. And sort of we also kind of get lulled into thinking that that is sort of a not that high of a dose, since that's what we have been used to prescribing for other people. But then if you try to do a dose calculator conversion, which is actually really, really also very difficult for methadone because of the variable idiosyncratic response, but generally 60 milligrams of methadone is roughly equivalent to 240 milligrams of oxycodone. So the fact that they come in these same milligram tablet sizes is dangerous and misleading. So given the slow dose, given the slow accumulation and the idiosyncratic dose response, you've got to really titrate methadone up very, very slowly and very carefully if you're using it for chronic pain. And so should we be using methadone for chronic pain? Maybe not. On one hand, the euphoria side effects from methadone may be a little less than with other opioids, and so the abuse risk may be a little lower, and that's sort of why it became sort of the cornerstone of heroin addiction. But that euphoria side effect is still present, and so I think that advantage needs to be somewhat tempered. And then there's all the disadvantages that I just talked about, that although methadone is long-acting by its prolonged ability to stave off opiate withdrawal, which is why it is so effective for treating heroin addiction. As an analgesic, it actually needs to be dosed 3 to 4 times per day. And that's like really weird too, because if you think about this super long half-life, you'd think of this as a long-acting drug that should be able to provide sort of analgesia in a long-term way, the way that, say, MS-Contin or MS-Contin might. But the reality is that the odd pharmacodynamics of the metabolites of methadone make it such that the analgesic effect of methadone really only lasts for 6 to 8 hours. And so as an analgesic, it really needs to be dosed 3 to 4 times per day. And so that's really kind of the crux of the catch-22, which is that on one hand, it's this short-acting analgesic, but then on the other hand, it has these long-acting serious adverse effects and long delay in terms of in terms of realizing its full efficacy. And so if people are used to using an opiate in a PRN way, if they're used to having some Vicodin on hand to use occasionally for their pain, and the methadone also only lasts 6 to 8 hours, you could sort of easily see how people would sort of slip into using methadone in a PRN way. But in that way, it can be incredibly deadly because of the gradual dose accumulation. So it's a short-acting analgesic, but if used PRN like other short-acting drugs, it can be deadly. All right, so now let's talk about stopping opiates, because part of the sort of rationale behind all the tools that I've been describing is really identifying people who shouldn't be on chronic opiates anymore. And when you find that somebody shouldn't be on chronic opiates anymore, then the next step is, okay, I've got to stop these opiates. But I would say that this is one of the most sort of difficult things for people to do, to stop opiates. One of the biggest sort of pitfalls that happens is that as that red flags come up, so minor or major red flags come up sort of over the course of years of treating somebody for opiates, with opiates, but they all kind of get sort of lost in the flow of the chart, you know. So a red flag happens, and then it sort of recedes into the past in the chart. And unless there is a centralized place in the chart, which really should be the problem list, where you are accumulating these red flags, it's really amazing how sort of blinded to the risk a clinician could be. And so I think the most important sort of tool, aside from urine toxicology screening, to identify inappropriate opiate misuse is to be able to track red flags in the problem list. When I do these chart reviews of difficult patients, part of the reason that it is so difficult, and part of the reason that it's so difficult for a pain specialist who you might refer a patient to do this assessment, is that if this tracking hasn't been done, then it's an incredibly time-consuming process to read through sort of 1 or 2 or 3 or 5 years of clinic notes to accumulate what all these red flags are, and then all of a sudden you put them all together and you say, you know, wow, this is a bad, dangerous situation. So if serious red flags occur and you've been accumulating these red flags in your problem list, and you suddenly realize that you are sort of in an unsafe situation, then you've got to stop opiates, just simply part of good, safe care. But that is just so hard to do. Again, like if this is somebody who you have been caring for years, you developed a good therapeutic relationship with them, there's part of you that really likes them, there's part of you that feels that in some way they probably are benefiting from the chronic opiates that you're prescribing, to actually sort of drop the gauntlet and stop the opiates is a really, really hard thing for people to do. The other sort of pitfall that happens is people think of stopping opiates as firing the patient or terminating care, which is absolutely ethically and legally wrong. You're not firing the patient or terminating their care from your practice. You're still absolutely willing to provide ongoing care. What you're not willing to do is to continue to prescribe opiates. But like I said, these clinical encounters are really one of the most stressful encounters that there is. I mean, I think it's right up there with having to sort of walk into an exam room and tell a patient that their CT scan shows cancer, in that the level of emotion and the level of tension in the room is really intense. And that's part of why there is this inclination to just kind of ignore these red flags as they sort of flow by in the chart, because dropping this gauntlet can be so emotionally difficult for a clinician. And so these encounters really require special planning in much the same way that you would sort of prepare yourself mentally to walk in and tell somebody that they have cancer. You have to mentally prepare yourself of exactly what are you going to say and how is this going to play out when you sit down with somebody and tell them that you have to discontinue their chronic opiates. And you've got to say just as clearly and straightforwardly as you can that it's just simply my medical opinion that this type of medication is not safe for you. But then you're not going to be done yet because the number of times when somebody is going to say, okay, and then sort of walk out is very, very tiny. What you're really going to get back at you is, well, what are you going to do about my pain? Don't you care about my pain? And in that situation, this is where the sort of preparation needs to come in. You've got to really be ready to immediately say, this class of medications I do not believe is medically safe for you, and so I believe that the safest treatment plan for your pain consists of, and you put together whatever the alternate plan is, whether it's NSAIDs or gabapentin or tricyclics or physical therapy or acupuncture. But then for the really sort of hardcore drug abuse patient who is misusing opiates, you're always going to get right back. I've tried all of those things, and those things don't work for me. What are you going to do about my pain? And that's really the hard sort of tension moment where you've really got to rely on empathy. And and this is a totally reasonable moment to feel empathic, because this is somebody who is in a terrible situation. If your suspicion, your likelihood that they are suffering from substance abuse is very high. And maybe they also have somatic pain or not on top of that, but this person is in a terrible pickle. And it's hard and it's weird that they are maybe sort of manipulating you and maybe trying to scam you, but they're also sort of in a sad situation. And so I think it's not that hard to be empathic and look them in the eye and say, I'm really sorry, and this sounds like it's terrible for you, and I'm sorry that you're in so much pain. But in my medical opinion, opiates are just not a safe option for you. And that's hard, and it's really tricky for people. But being prepared and sort of feeling strong about, in the long run, that is the right thing for the patient and the right thing for medical care is the way to go. All right, so now I think we're gonna, before I go for questions, I'm gonna give you just two other little tidbits of other resources to use. One of the best developments that's happened in the state of Washington in the past year is that we finally have a statewide prescription monitoring program. So we're one of the last states in the country to adopt this. It's sort of fraught with ethical patient confidentiality issues that we have overcome by a very somewhat cumbersome user interface. And so I'm not going to get up here and pretend that this is sort of super fast and easy to use as you wish it would be. And yet it is still extremely, extremely valuable at identifying patients who are doctor shopping. So this allows you to type in a patient's name, and I generally say, rather than searching for their date of birth with an exact match, it allows you to search within a sort of 2-year time frame, and it allows you to see all of the controlled substance prescriptions that patient has picked up in any pharmacy in the state of Washington in the past year. So it's a really important, good thing. And then in terms of other tools, The pain medicine provider toolkit is now available on the desktop of every UW Medicine computer. So on the UW Medicine desktop, there is a clinical toolkit, and if you click on the clinical toolkit at the top, you'll see the pain medicine provider toolkit, which gives you an easy link to the prescription monitoring program, an easy link to an opioid dose conversion calculator, and much, much more. And so use the pain medicine provider toolkit. And so with that, we have time for questions.